Hello, everyone. Thank you very much for joining. My name is Adina. I'm one of the Specialty Careers webinar leads, and I have my colleague Dr. Patel here as well, who is the Specialty Careers article lead. Thank you very much for joining this Specialty Careers webinar. Dr. Dominique Calilung will talk us about the career in forensic psychiatry, so I'll just hand over to Dominique. Thank you.
Thanks, Adina, and thanks to Kostov for linking me with this presentation. So, hi everyone, I'm Dominique. I'm an ST4 in Forensic Psychiatry. I work in Bristol under the Severn Deanery under AWP Mental Health Partnership Trust. So, I'm going to give an overview about forensic psychiatry, which I will delve into. So I've made an outline here. So again, just kind of defining what forensic psychiatry is, what is recruitment like, and then I'll explain how services are delivered in the healthcare system here in the UK. So we've got just letters there, SWPC and ICB, which I will explain later on. And then I'll briefly speak about my NHS Trust and how we work with different organizations in Bristol and the Southwest region. Then I'll touch on my training, how I got here, how I got into the UK and into this higher training program, and also kind of just giving an idea of what the curriculum is like for forensic psychiatry as set by the Royal College. And then we'll move on to life as a registrar. So what my work week is like. And also just to highlight that there's so much variation with what a registrar can or cannot do. So there's a med reg and there's a psych reg. So I'll just focus on forensic psychiatry because general adult psychiatrists, CAMS psychiatrists, they have a completely different framework. So I'm not going to touch on that. And also just mentioning about special interests and why it is part of the curriculum. And yeah, I'll aim to leave some time for questions. And I think Adina will call me out on that if I'm lagging on time. And I'll leave my contact details if you have any questions about my talk tonight, or if you're just curious about considering forensic psychiatry as a career. So I would define forensic psychiatry as a multifaceted specialty in medicine. So in simple terms, it's the interface between psychiatry and the legal systems. So it's based on detailed knowledge of relevant law, criminal and civil justice systems, mental health systems, and the relationship between mental disorder, antisocial behavior, and offending. So your role really is to assess, treat, and rehabilitate offenders who have...
Sorry to interrupt.
Yeah.
I think people are unable to see the slides.
Okay. I'm on slide 3.
Okay, I think they can see now.
Okay. Maybe it just takes a while because maybe I think it's kind of graphic heavy.
Right.
Yeah, but let me know, and then I'll try to switch it up. Okay. So yes, so it's an interface between two fields, basically mental health and law, but I would say it's a lot more than that because you've got different systems, again, legal systems, mental health systems, and there's the relationship between mental disorder, antisocial behavior, and offending. So your role is mainly to assess, treat, and rehabilitate people who are involved with the criminal justice system with mental disorder or have the potential to be violent. So that means if somebody who committed crime is known to have ongoing mental illness, you treat them under forensic services. Or if somebody in prison, if a prisoner is on remand and develops mental illness, then you treat them as well. And under the Mental Health Act, you can transfer somebody from prison to a forensic hospital. And that leads me to the next bit here, which is risk, which is really the core feature, I believe, in this specialty. You're always assessing risks, and in a range of settings, and that you can express this in many ways. In this work, like where you are called by the court to provide psychiatric reports. You can give oral evidence in court. You're liaising and advising several professional agencies. So just like for example, a general psychiatrist who can liaise with drug and alcohol services, social services. So with forensic psychiatry, it involves, so it's also, there are similar services you link up with, but at the same time you are also providing your expertise again with legal bodies. So that's the Ministry of Justice, magistrate court, crown court, and there's this legislative framework called MAPA, which stands for Multi-Agency Public Protection Arrangement Panel. Sorry, I had to write this down because I can never remember. It's designed to protect the public from serious harm by sexual offenders, violent offenders, and other dangerous offenders. So again, it's a partnership between police, prison and probation services, and again, because these offenders have mental illness or a history of mental illness, then you are invited to attend these meetings, and they are mandatory. But at the end of the day, you are a doctor, you're a psychiatrist, and this is why these other these assortment of bodies are relying on your medical expertise in terms of patients, who deteriorate in mental state, leading to mental disorder. And as a psychiatrist, you are still dealing with physical aspects, given that psychiatric medication present with so many physical side effects and complications. So you are, so in the hospital where I work, I still have, an SHO colleague, and obviously there's a consultant, and there are, it's basically the same when you work with the nursing team, social worker, OT, and we still ring the MedReg for advice. We still bring patients to the general hospital in case they develop physical health concerns. So I'm moving on to the fourth slide. So let me know if you can't see it. So I've just included here screenshots from the recruitment website from NHS England. So as you can see, we're quite a small bunch. In 2022, there were 19 posts that was completely filled. And it's a shame, really, because they started to cut down on the dual posts. So there was only one post for a forensic psychiatry and medical psychotherapy post. So that becomes, instead of a 3-year higher training program, that becomes 4. So you do your core psychiatry training for 3 years, CT1 to CT3. And then you become an ST4 when you enter higher training. So if you're in a dual post, whether it's general adult plus old age, or in this case, forensic plus medical psychotherapy, then you reach up to ST7 before you CCT. So last year, there were about 30 posts, 21 were filled. So I started in February, and when I was applying for forensics around this time last year, there was 26 posts across England, Scotland, and Wales. Oh, and just if anybody is interested to become a higher trainee in psychiatry, there is also a point system where you submit evidence, and there's also an interview. So moving on to the system. So you've got here a picture on the right, which tells you the different NHS trusts that work together under a integrated care board. So integrated care board is, it's a legal term. So it used to be called CCG, the Clinical Commissioning Groups. And so as a legal entity, they can develop plans on how to assess the healthcare needs of the population, especially with more specialized or complex needs. They manage the NHS budget, they commission services. So they involve a provider collaborative. So because I'm in the Southwest, is the Southwest Provider Collaborative. Sorry guys, really boring stuff, but I'm going to make a point here. So the reason is secure services is quite, it's complex needs. So the SWPC makes it possible for more integrated and specialized healthcare. So we provide, the SWPC provides like a CAMS Tier 4 service. So just for children with mental disorder that have more complex needs, adult eating disorders, mother and baby unit, and it spans really from Cornwall to Gloucester. So that's quite a wide geography there. And the aim is to let patients live as close to their homes as possible. So for example, if there's so at this point in my training, I'm not really sure what the regulations of prison is with moving around prisoners. But let's say, for example, if there was a prisoner in Devon, in a prison in Devon, and he developed mental illness, and he needs to be treated now in a secure unit or a forensic hospital. If that prisoner lives in Bristol or has family in Bristol, then we are the assessing team. And if he gets admitted, the ideal situation is for him to be admitted in a forensic hospital in Bristol. So that's how it works. So sometimes in my work, when I have to assess, let's say, a prisoner or somebody in PQ. So in prison, for example, I've driven as far as in the Midlands, like a 2.5-hour drive, and then assess the prisoner, and then drive back to where I work and just hand over to the consultant, see what they think. So it's really a whole day. It's a whole day's work. So sometimes there's one day in my schedule if there's an urgent assessment of somebody in prison and there's really concerns that they're really, really unwell, then I don't have to do my work in hospital, and obviously I need to do I need to do my work outside of it. So yeah, I hope that makes sense. Why there's a need for the provider collaborative, and different regions has it. So there's London Provider Collaborative. There's also in the north. Okay, so by definition, so I've been mentioning secure services. So that just means obviously a service with with a level of security. And in forensics, it's 3 tiers. So there's low secure, medium secure, and high secure. So Broadmoor, I'm sure some of you here might have heard of it, is a high secure, or I guess in America they call it like a maximum security or maximum detention hospital. So the NHS England defines patients' liability to be detained under the Mental Health Act, and the risk of harm to others and risk of escape from hospital cannot be managed safely within other mental health settings. So again, I've just, highlighted there the term. So if it's low secure, they present a significant risk of harm to others. Their escape from hospital should be impeded. For medium secure, they present a serious risk of harm to others. And if they, escape should be prevented. And finally, with high secure, they present a grave and immediate risk to public and who should not be able to escape from hospital. So I guess, for example, if you come in a low secure unit, I haven't worked there, but I believe, for example, you'd probably have to surrender your phone if you were visiting. But in a high secure, I'm aware that even if you're staff, because I did a shadowing there quite recently, even if you're the consultant, you need to leave your phone in the car. Like you can't even bring it inside because of the security, and you pass through like an airport security. You get the full body scan, and there's so much. So the more secure the hospital, the more restrictions, and that goes definitely for patients as well. Okay, so moving on to localities. So my trust, even in a wheelchair, it's the lead provider of healthcare for people with serious mental illness, learning disability, and autism. So it covers quite a lot, including Bath and Northeast Somerset, Swindon and Wiltshire, and the BNSSG, Bristol, North Somerset, and South Gloucestershire. In August 22, Oxley's NHS Trust, the London Trust, was awarded the Southwest Prison Healthcare contracts for 10 prisons in the Southwest. So, and I'm going to talk more about that. Okay, later on. But for now, I'll just describe my work site. So there's a picture there. Yeah, so currently I'm in a medium secure, which is 80 beds. It includes like an acute ward. So somebody presents like high risk, or usually an admission comes through the ward that I currently work on. So usually if you're ST4, you're placed there because it's a lot of learning. Like you can see the process from transferring somebody from a PQ is like psychiatric intensive care unit. So for people who are not from the UK, or people who are who haven't rotated in a PQ, it stands for psychiatric intensive care, not like a medical ICU. So if somebody is being transferred from a PQ to a secure hospital, and then where was I? Okay, so obviously, for example, we have a PQ in Bristol, and if somebody is being transferred there, then it depends whether it's low or medium secure. And then again, if somebody is being transferred from prison, depending if they are from Bristol, then the ideal situation is for them to be transferred to us. But again, if there's no bed availability, so we do have 80 beds, but you know there's an acute ward, like I said, where we get the transfers from PQ and prison. There's a rehab ward. There's a female ward. And then with low secure, I think it's completely male wards. So yes, again, the admission process is much slower compared to like somebody in a general hospital, but much slower as well compared to like physical health admissions. Okay, so yeah, so I mentioned prison. So my contract is with AWP, but I have an honorary contract with Oxley's because, as mentioned before, Oxley's has kind of is now the responsible trust for these prisons in the Southwest. So I do have an honorary contract with them, and I work once a week under a clinical special interest as per the training scheme of the deanery, and I will touch on that later on. So having training in prison and having experience in prison for a year is the recommended training competency to be achieved whilst you're in your registrar years. So I've just put there bits from the curriculum saying that you must practice psychiatry in prison, including in their key capabilities. You must have an understanding of the nature of the environment, adapting the skills, recognizing what you can and cannot do. Because again, as I've mentioned, you're working with legal systems, and it's not always straightforward. You must have an advanced knowledge of the prison estate structure, the wider criminal justice system in the UK. And again, you must provide effective clinical leadership because again, you are working with prisoners and the prison mental health team. But again, you are also working with non-healthcare agencies. So just thinking about if somebody is has been treated for their mental illness, and they serve their sentence, and they are actually going to be released and discharged to the community. What does that mean? Like, which agencies do you need to inform about this patient / prisoner? So it's a lot of, again, just letting people know about the risks. And in forensic psychiatry, any added information is always welcome. Like the more information we have, the better, even if it's repetitive. We never turn down information about the patient. So that's a picture of the male prison where I work. So again, I just put the logo there because it's under it's under Oxley's, and that's just a picture on the right, just what the prison ward is like. So I work with the psychiatrist. I never assess a prisoner by myself. I always need to be with a mental health nurse or the psychiatrist. I do have some influence on making decisions. But again, it's an honorary contract. So again, there's just kind of just that boundary between, between what you can do. So my journey, to getting to where I am. So I'm an IMG. I moved here from the Philippines in 2020. My first job was I was a trust doctor in a mental health services for older people. And then I just jumped straight into training in 2021 of January. So I'm here for about 4 years now. And then I stayed in that deanery for the whole 3 years, and then last year I gained my membership to the Royal College. So I transferred deaneries because I wanted a change of environment. And personally, I like Bristol as a city. Okay, so I've just copied some bits here from the Royal College curriculum about what is expected of a registrar. So to simply describe it, the higher you go, the more independent you are. So in your portfolio, when you start logging in your workplace-based assessments or your cases, so sometimes you get assessed for I can't speak for other specialties, but let's say if you were to assess a patient, usually a consultant is there to observe you, how you assess and how you diagnose and how you speak to the patient about management. But because as a registrar in forensics, so for example, if you go to prison, let's say as far as Devon, and you assess somebody, you're the senior member of staff, so there's no consultant to observe you. So our portfolio is more of case-based discussions rather than like real-time observed assessments, because there's expectation that you can make these decisions, and there is, I would say that you have a lot of influence, you have a lot of power as to the movement of patients and offenders in the country. So yeah, I really have developed an appreciation of that. And the consultants trust you more. But again, there's always that support. So you're kind of in the middle. You have a resident doctor who's like covering the ward, like with the physical health bits, which you are expected less expectations for you to do, but I wouldn't say you're exempt from it. And yes, you still have a supervising consultant. So as an ST4, it says here you bring evidence base regularly into clinical decisions in line with best practices, and you plan the research activity, and you show evidence in supervision. So planning the research activity. So you're expected to do research at least once in your specialty training. And again, you can do this in the form of a QI. You can do a systematic review, meta-analysis with a team. It really depends on you. You're not going to be spoon-fed or told what you can do. But you will be given time for this, and I'll tell you how, because the Royal College makes sure that there is time to do all these non-clinical development competencies. So when you're an ST5, you're able to recognize the limit of the evidence base, and you're able to work safely beyond that. So that just simply means if you have an assessment about somebody, or I don't know, you have to make a decision for a team, you know the limit of your role, and you know the limit of the medical team in the wider forensic system, like in the wider interface of medicine and law. So you know what you cannot do. So you know who to speak to when there's a certain issue. And also, just says here, shows progress being made in the planned research activity and shares outcome of research. So again, just kind of being more independent. And finally, in your last year, you pursue your own area of academic interests. So I know some registrars who manage to do a PG cert, a PG dip, a part-time master's. They've gone on to taking management roles, or finding jobs for themselves, securing themselves a consultant post when they reach ST6. They're able to disseminate research outcomes in appropriate ways and forums. So again, once you finish your research, you're free to do an oral presentation overseas, ask the senior member of the team. You collaborate with different trusts, different organizations. And yeah, obviously the goal is to use that research, whatever you've learned in your training, to influence MDTs and guide service development. Okay, so you're Reg, now what? So I already touched on this. So your senior role, you have a senior role working more closely with the consultant. I would say you're co-captain of the ship. You're not quite captain of the ship yet, which to me gives a nice kind of feeling of relief and security. But then you are also encouraged to like make decisions. So if you have an admission and the consultant says, he's under your or she's under your caseload, like I have more decisions about, choice of medication, switching, trying this, trying that, and then and obviously knowing my limitations, to what I can or cannot do. So, for example, if somebody's in a psychiatric hospital, in a general psychiatric hospital, obviously where you're not under the criminal justice system, consultants can prescribe leave. So that just means you can tell the patient, you can go out of hospital, you can have a cigarette break by the grounds, okay, and we'll have like a member of nursing staff like walk with you. Or you want to go to the shop, you want to buy something, that's fine. Easy, like fill out the form, like easy in like 10 minutes. So because it's forensic psychiatry, and this is what I've been trying to reiterate in the last several minutes, there's more risks, there's more nuance, there's more steps. So you cannot just prescribe leave. You need to be writing a report that needs to be submitted to the Ministry of Justice, and that can take, days, weeks, months, depending on the complexity and the dangerousness of what that patient presents. So obviously, if you believe that this patient has reached a level of stability and good therapeutic response, to medication, to psychology, occupational therapy, and whatnot, then that's what you write in your report. You can say that they've been working well on the ward, they're settled, they're incident free, they're taking their medication regularly. My recommendation is that, we take positive risk taking, and we can actually let our patient go to the shop or go to town. So if you think about it, it's something that, yeah, I think being in forensics just kind of makes me appreciate the things that we can do. Like, it's freedom basically. And if you're in this field, you're deciding like the level of freedom that you wish to give this person, but at the same time you have to protect the public. But then again, it's also a balance where you cannot keep somebody in hospital forever. So there's that element of positive risk taking. So yeah, it's always constant risk assessment, constant, like, it's a delicate balance, all those bits. So I've put here a picture of a sample work week, and you can just read through that. And whilst you do, I can just briefly explain my work week. So on Monday, I do a handover from one of the wards. I get it's online, so so I can attend that from home, and then I pop into work later on, or I can just show up. If it's urgent, obviously, then I have to come in. And then in the morning, I tend to finish reports, like go through emails, finish the report. So if I'm writing a court report, if I'm writing a report about granting somebody leave, and basically it's different kinds of reports, I leave that in the morning. In the afternoon, there's another handover from another ward, and that's face to face. In the afternoon, it could be anything really, like writing medical recommendations. Yeah, it's all gonna sound really boring now, but it's a lot of writing. It's a lot of writing throughout the day. For Tuesday, that's where I go to the prison where I work for my clinical special interest. On Wednesday, so if you remember the terminologies I mentioned to you guys, the SWPC, the Southwest Provider Collaborative. So there is a meeting that occurs once weekly, and that's where like consultants, ward managers, and the panel, the SWPC panel, they pretty much discuss. And if you remember that picture where there's all those like trusts, like from Gloucester, like from Cornwall to Gloucester, so they do discuss, like they allot like a few hours for this day to talk about referrals, admissions, transfers, who needs to be assessed urgently. I'm not required to join that, but I did just for my learning like a few times, because obviously the outcome of that meeting, let's say, oh, somebody needs to be assessed really urgently. The prison mental health team is concerned. And again, if they're local, if they're from like Bristol, Bath, Swindon, Wiltshire, then I get an email from my consultant saying, can you do this assessment? It's quite urgent. Wednesday is also it's time for like a case consultation. So if you're a consultant and if you want to seek advice from your colleagues on how to manage a patient, because patients can be really complex. And again, it takes ages. I just had a manager's hearing today where about a patient who's been in hospital for a long time, and I can give you a range. People in forensic hospital can stay from about maybe 2 years, and sometimes people spanning up to 20 years. Yeah, so it's so variable. So sometimes you can attend these meetings as well. You can attend the tribunal. If people here are familiar with a medical tribunal, you attend that. You're the person who gives oral evidence. So again, usually it's the consultant, but because it is part of your training to become more independent, sometimes they just let you give oral evidence, and they're not there anymore. You just kind of in your next supervision, you just talk to them about it and discuss it. But obviously, again, if you have difficulty with the process at any point, you just speak to them. They're always around. Thursday is ward round. So again, if the consultant is not around, then the registrar leads the ward round, and that's quite a whole day affair. That gets pretty tiring. And for Friday, at least for my Friday, it's my non-clinical special interest. So again, just mentioning in the curriculum, there's a clinical special interest and there's a non-clinical special interest, and I'll tell you later on what that involves. So again, on Friday, I'm not in the office because of the non-clinical special interests. Okay, so for the clinical bit, so in the curriculum, I think as far as I'm aware, I think it's the only deanery that gives you 2 days for a special interest. So one clinical and one non-clinical. For clinical, you can, so it's basically it's like an elective where obviously it's still a working contract. So you can pursue it in a forensic services for women. You can go to an elderly forensic unit. You can work with consultants who manage, really complex schizophrenia or treatment-resistant schizophrenia who are, again, offenders and under the criminal justice system. You can do an adult ADHD clinic. So that's going to be my next special interest. I'll be shadowing one of the Bristol, well, not just shadowing, but working for the adult ADHD clinic in Bristol. There's a memory clinic, eating disorders unit, and FIND, which stands for Forensic Intellectual and Neurodevelopmental Disability. Yeah, so that's people with again, learning disability, severe autism, again, really complex patients, but they are offenders. So, and there's a whole, like, if you just do a quick Google, there's a whole field separately for people with autism and ADHD offending. So, for example, in prison, 30% of the population have ADHD, and again, that calls for that kind of the Royal College has been calling for the government to give more funding for ADHD services, and knowing that there's such a long waiting list. I think it's 7 years now, but again, obviously there needs to be more support for people with neurodiverse conditions. Okay, for non-clinical, so this is quite a mixed bag. This is your time to do research. If you want to do a quality improvement, you want to do some teaching, you want to get involved in a leadership role, it's pretty much it's whatever you want to do. So at the moment, I just recently finished a certification course in public mental health. So it was the first cohort by the Royal College of Psychiatrists, and I recently finished that. If anyone's keen, just let me know. I can pop it in the chat. For my next non-clinical special interest, I recently joined the Leadership and Management Fellowship Scheme, also by the Royal College. But again, this is really like flexible, and you can choose the day where you want to assign it in your work. Again, if you want to pursue a master's degree, another, educational degree, like by all means, as long as you just, inform your line manager and make sure that obviously your competencies in forensic psychiatry are not being compromised. Yeah, I think that's pretty much it. So I've just put in here the resources. Obviously there's a faculty of forensic psychiatry in the Royal College website. So all the news in terms of like recruitment, numbers, number of vacancies, events, conferences, awards, get involved if you're interested in it. If you're keen to get into psychiatry training, or if you're a psychiatry trainee, there's a Twitter / X account. They're pretty responsive on there. From the end, there's also the NHS England higher training recruitment, where I got the pictures from, and I put the email there as well if you just want to know more information. So they're quite responsive too. And yeah, if you like books, reading books, forensic psychiatrists, a few of them end up becoming authors. So on the left, it's by Gwen Adshead, who is a psychiatrist in Broadmoor. I've met her a couple of times in conferences, and I've read that book as well. It's a story. It's a book where she kind of tells a story of the patients she's interacted with through medical psychotherapy. So I think she's a dual forensic psychiatrist and medical psychotherapist. They Got Dangerous Minds by Taj Nathan. I'm currently reading that. Quite similar, and he kind of explains the patients he's seen, under his caseload throughout the years, and kind of explaining violence and dangerousness. But I think what's important with these novels is that, because I think it's so easy for us to condemn offenders, because obviously what they've done to society, it's not great, it's not good, and there are victims and families of victims. But at the same time, I do acknowledge that nobody's born an offender, nobody's born with intent to take somebody's life or to kill somebody. So that's what I appreciate about forensic psychiatry the most. You're not just a medical doctor, you're almost like a public health advocate as well, because you need to be studying from the beginning, just the childhood history, what led this person to resort to violence as a coping behavior. Why is their first intention is to punch people instead of just having a conversation? How did he get point A to point B? And I think if you're just eternally curious about those things, then I'd say maybe it's worth considering pursuing. Also, if you like thoroughness and spending at least 6 months with a patient, then yeah, it might be worth pursuing. The last book, I haven't quite read on it, but it's got more of there's a bit of dark humor in it. I'd say it's lighter. But yeah, I'd encourage you to look into these books if you're curious about the field. Yeah, thank you very much. Probably the last thing I'd probably say is that at the end of the day, you after all these risk assessments, I think being a doctor, your ultimate goal is to help people, and that really involves a lot of compassion with the way you deliver your care for forensics. So yeah, that's me. Thanks very much. I've left my contact details there for anybody who has any burning questions. Maybe not now, but later on.
Thank you very much for this fantastic talk, Dominique. It was really great. I just have one question for you. So you mentioned that you joined as an SD4 trainee. Do you have any piece of advice for people that are looking to join at SD4 level in order to make themselves more competitive for the application process?
Okay. I feel like I'm going to answer this question with expressing my dislike for the process, because so in similarly, it's kind of in surgery, you have a point system, right? So in ST4, there's also a point system, and some of those things are not quite constructive. So, for example, if you completed another specialty, like if you were a radiologist who jumped into psychiatry because you have an extra degree, you have more points. So I feel like that's not quite fair. But if you happen to be that, then that's to your advantage. If you have any publication, that's really something you want to work on early. So when I was a CT2, I just kind of briefly went through the point system. So I told my supervisor I want to work on a publication, like, because it could determine the 1 point that sets you above the other applicants. If you have an award at some point, if you have presented in a regional or a national conference, so the Royal College International Congress, it's a really good opportunity, because if you get to present a poster, you don't even have to speak orally. If you just get accepted to it because it's an international congress, then that already falls under like the international presentation. The interview is probably around 15 to 20 minutes long. They do it online now, I think, because of the pandemic, and they haven't really reverted back to face to face. The 2 questions will be given to you guys in advance. It's going to be on the HEE website. I think they give it about 2-3 weeks before. But to me, that makes it even more difficult because everybody knows the question before the interview. And they tell you, we discourage rehearsed answers, or we discourage you memorizing your answer. But then at the same time, like, who wouldn't try to memorize a little bit, right? So I think it's like balance. Just practice with somebody, again, because if they feel like it's rehearsed, then I guess you lose a bit of points. So it's just finding that balance between, you have a outline in your mind, but again, you're like kind of confident for like the follow-up questions that come. Also, it does come in waves, because I think in higher training in psychiatry, most people take it as a chance to get pregnant, have a family. So it's these numbers, because it's a shame they're not increasing the numbers, but obviously there's more demand for core training, so it kind of bottlenecks. So yeah, it comes in waves. There are times when sometimes the February intake is more than the August for certain subspecialties. Yeah, so I just say if you've decided on what higher training you want to get into, just keep an eye out for the news and try to see the trends if February or August is more feasible. So yeah.
That's lovely. Thank you very much for that answer. That was really great and a lot of detail in there. We have a question in the chat.
Okay.
Can I just check if is forensic psychiatry less than full-time training friendly? I can imagine that if that would affect the schedule planning.
So psychiatry, I think, is one of the LTFT friendliest specialties. In Severn Deanery, we have an LTFT champion. There's even a WhatsApp group for like Severn trainees, like family matters. So it's so specific. I feel like there's such solid support, and they even conduct these like support sessions for LTFT trainees. So what happens is, so for example, if you're already doing a clinical and a non-clinical special interest, technically you only have 3 working days left. So if you're gonna go down LTFT, you have to prioritize your training as a forensic psychiatrist. So adjustments could be made where you could do just half a day of your clinical special interest, and then you still do like half the clinical work. But obviously the workload is still, it still reduces, obviously, but just in terms of ensuring that you still have your special interests in. So again, this is very flexible. Yeah.
Great. I don't think there are any more questions at the moment. But yeah, it's somebody has asked. Can't believe there's only one post in the whole country, though. I don't think there was.
Oh no, it's one post. So for Bristol, it was one post, but it's not. So in 2022 it was 30. No, 2019. 2023 was 30, and for the February 2024 intake this year, it was 26. But that's for England, Wales, Scotland. I can't speak for Ireland, but I really think they should be increasing it. Yeah, it's a shame.
So you don't have to do like ward rounds every day?
So ward round is once a week. But again, for example, my consultant, her approach is Thursday is ward round day, but she sets another day throughout the week to just kind of like do like a mini ward round, because that's how you establish relationship with the patients,
Mm.
because we're talking about patients who are in hospital for 6 months to a year. So it's almost like if you do a ward round like every day,
Yeah,
yeah, it's almost like, yeah, what's your ultimate goal with it? It's almost like you're just tiring yourself out. So it's more like timing it strategically and what are the urgent issues that arise
yeah.
for that week. And there's handover as well, but ward round wise, yes, it's not as often compared to a medical job.
Mm. Do you generally finish on time?
Yes, I finish on time. I do have my lunch breaks. There are probably the days where I don't get to have a lunch break is when, for example, there's a meeting at lunchtime. Like literally, I cannot go and have a break because there's a tribunal, a manager's hearing, basically a really serious meeting that you just have to attend. But the thing with I don't know, maybe I'm just gonna talk about the the trust that I'm in, but the consultants are extremely supportive. I think there's a level of trust that you establish with them, and
Yeah.
for them it's about like they're not gonna police you. Like I remember my TPD telling me, my training program director telling me, if you didn't come to work for like 2 days in a row, like I wouldn't think that you were, trying to avoid work. I would be worried like where you are, like what's happened to you. I don't know if it's the nature of the job, but it's almost like it's really like the team looking out for each other.
Yeah.
And it's flexible. Like if there's a handover, and for example, you have to only attend online, then you
Mm.
can do it. That's why a lot of people find it feasible for childcare, and if you have to leave early, for example. So the prison consultant that I work with, she's a general adult psychiatrist. So she has childcare and all that. So what she tends to do is on Tuesday, she works from 9 to 7 p.m. But then on Friday, she leaves at 3 p.m. So
Right.
it's almost like you kind of just, as long as you achieve your 40-hour work week, as long as you ensure that you're meeting your training competencies, you're getting the work done. Yeah.
And do you have to do on calls?
Oh yes. Oh yeah. I forgot to mention that. Good question. So in if you're a forensic reg, so we're quite isolated. I don't know why, but I have my induction. I didn't have any like first day induction. I was quite separated from all the rest of the psychiatry regs.
Yeah.
Um sorry, what was your question again, Costa?
Well, do you have to do on calls?
Yes, so for the on call, we are on a separate forensic on call rota. So it's one every 15 days. So you're expected to be on call from it's a 24-hour on call now, so it's 9 a.m. to 9 a.m. the next day. But again, it's non-residential. So
Okay.
after you finish your when the clock hits 5 p.m., if
Yeah.
there's no pressing issues, then you can come home. And I think the reasons that you just need to come in is if somebody is sent into seclusion because you have to do. And
Mm.
here's the thing: if you're an SHO, if you're a junior resident doctor, if you're a core trainee, you have to see the patient within 1 hour. But if you're a reg or you're the consultant on call, you allow for like 6 to 8 hours. So there's a lot more flexibility there because again, you're not on the ground, but you're also making some decisions. So if somebody was sent into seclusion at 2 a.m., the SHO can ring you, but you're not really obligated to come in the wee hours of the morning. You can leave it for the next day, and
Got
you
it.
can do swaps. On a weekend, we do every 6 months. We do have a 48-hour weekend on call. So it's basically from 9 a.m. Saturday to 9 a.m. Monday. Again, it's non-residential, and we do get Monday and Tuesday off. So
Got
even if
it.
it's not, so you get your time back, and for time that you weren't like literally like working like you're not running around like a headless chicken for the 48 hours.
Yeah.
But again, it's more complex because we get calls from the police station, we get calls from prison. There are emergency transfers, and I've seen a consultant on call work like 6 hours on her desk on a weekend because it was just such a serious. I think something serious really happened. So it's quite variable, but I would say that is not as common as a usual on-call.
Great. That's quite informative.
That's really interesting. Quite different to the medical on-calls.
Yeah, absolutely. Yeah, absolutely. Yeah. That's why I have so much respect for like the medical. I would say, I don't know, what I describe as busy now isn't quite. So I'm
It's
quite
good.
careful.
Yeah.
Yeah.
I think that's a factor that everybody should consider when they apply for training.
Yeah.
Without
I
that.
think also as well with forensic, it's more of because I did like highlight, you have power with people's freedom, and I feel like even if you are not physically exhausted, but the process to make these decisions, and when you write your reports, because the judges read your reports, they make decisions in court, they do rely and listen and read and accept your recommendations. So it's almost like you really have to know what you're talking about. And again, this is a slow process. Like I feel like in my SD4, I'm barely like every of the consultants need to read my report completely before, and they do tend to like make revisions and amendments. Again, it's a process. I feel like even if you're already in your early consultant years, it's not going to be that, it doesn't mean you already know everything. But yeah, slowly but surely and safely, I think is.
Thank you. We've got a couple of more questions in the chat.
Okay.
One of them is if you have any ideas about the CSER training in forensic psychiatry, sorry.
CSER for forensic psychiatry. I haven't encountered somebody who has done that. I think it's possible. I might be wrong, but I think with every CCT, you can apply for CSER. Unfortunately, I do not know anybody yet on the forensic pathway towards CSER.
Thank you. And the next question is, do trainees have to attend court for proceedings?
If you are no, because it has to be the responsible clinician who is the consultant. So if there's, for example, a sentencing, a patient who is in hospital is going to be sentenced and the court has asked for oral evidence, then it's going to be the responsible consultant. But if you are a trainee who has accepted to write a court report for somebody in prison, so it's almost like if you're a forensic reg, you're doing some independent work. So for example, if I write a court report, that's being, and the payment is sent, for example, you're being paid by the solicitor. It doesn't get taxed in your payslip. So, and I've recently realized this. So now I have to declare it now as a self-assessment on the HMRC website, because you're doing independent work. It's almost like you're a sole trader because you're providing services for somebody outside your work contract. I'm sorry, I forgot your question now. I feel like I'm being tangential.
The question was if the trainees need to attend court.
Yes. So for example, if you wrote a court report, and if they want like additional evidence, or you might need to come in for oral. Usually, if you provide a written court report, they don't. But I think if it's more complex, if they would prefer oral evidence instead of a written court report evidence, then you might be asked to come in.
Thank you. I think that's all of our questions. Thank you very much for your talk and for your time this evening. It was very informative. There's a lot of thank yous coming through in the chat.
Okay. Thank you very much. I hope it wasn't too boring with the terminologies, but yeah, it's something to consider. It's a really interesting field. Thank you.
Thank you very much.
And have a good evening, everyone. And don't forget to fill in the feedback form in order to receive your certificate. I put the feedback link in the chat, and you'll also receive an email from Meadow. Thank you very much for joining us.
Thank you. Bye.